You're on mute, Liz.
First, well, mistake of the morning. Welcome very much to the GambleAware webinar. Thank you for joining us. This is my first of these webinars, and I'm your facilitator for. I'm Liz Barclay, and I was previously a trustee of the Responsible Gambling Trust before it became GambleAware. Our webinar this morning is understanding how to estimate gambling prevalence, identifying the reported demand for treatment and support at a local level across Great Britain. So in effect, the webinar is in two parts. Now, let me just give you some context to that. On the 14th of May, GambleAware published new research into how methodological differences between surveys affects the accuracy of estimates of gambling harms. The research was commissioned following the 2019 YouGov study, which found substantially higher rates of gambling harms across Great Britain than had previously been reported in the health surveys for England in 2016 and 2018. And the research was commissioned to identify the best way to determine gambling participation and prevalence of gambling harms in Great Britain, and to develop a better understanding of how methodological factors might account for the different results of the YouGov study and the health survey for England's results. Now, GambleAware commissioned the research because it wants prevention, treatment and support commissioning to be informed by the best available evidence. And we'll be hearing from the report's author. We'll also hear from GambleAware on using gambling harm prevalence data to determine demand for treatment and support at a local level, and from Greater Manchester Combined Authority on how the data collected by GambleAware and there is sufficient treatment and gambling harms in place. Now, the only point of housekeeping that I have this morning relates to asking questions. You'll be on mute throughout the webinar, so therefore, sadly, you won't be able to verbally pose your questions. Use the question box on the top corner, left-hand side as you look at the screen. Type your question into the box provided when you click on that button, and I'll then pass the questions on to the speakers once they've finished their presentations. We should have a few minutes for questions after the first speaker, and then a second chunk of questions after our second and third speakers. And any questions that we can't cover because of restrictions on time, we will follow up later after the seminar. So let me introduce our first speaker, and that is Professor Patrick Sturgis from the London School of Economics, who's the author of the methodology review to determine how to calculate best the prevalence of gambling harms. Professor Sturgis, thank you very much for joining us.
Thanks, Liz. Okay, I will now attempt the screen share. Okay. Right. Okay, so now I can't see anyone other than my own reflection in the computer, so I'll assume everything's going well unless I hear otherwise. Yeah, so as Liz said, I'm based in the Department of Methodology at the London School of Economics, and this is a joint report with my colleague Yoni Kuhar. I'm going to have to go through it pretty quickly, given the amount of time, and there's a lot of detail in the report, so I'm going to have to at various points refer to that detail rather than go through it here. But obviously there's a bit of time for questions, so hopefully that will provide sufficient forum for that. As Liz said, the background to this report is that the official statistics for gambling harm and gambling prevalence have for a long time been collected using a particular survey methodological design. And most recently, this was done via the health surveys, the Health Survey for England, Health Survey for Scotland, and they in 2016 and 2018 recorded, I mean, whether they're low or not is a matter of subjective judgment, but the rates were 0.7 and 0.4 for gambling harm, and risk of gambling harm was a bit higher at 4.2 and 3.9. Then in 2019, a YouGov survey, which was actually, the intention was not really to estimate that quantity, but to look at demand for treatment services and so on. But nonetheless, that came up with much higher estimates, so about 3 times or more higher than the previous surveys. So this led to an obvious question about which is the more accurate estimate of this very important number. And they use very different methodologies. The health surveys and the surveys prior to the health survey use a probability sampling approach and in-person interviewing, whereas the YouGov survey used a non-probability sample, and the questionnaires are completed by the respondents online. So I was commissioned to write a report into this, which was looking at the various factors that might lead to differences in estimates. And really what I concluded there, well, it's very difficult to know with any certainty, or at least based on empirical data, what the more likely survey is to be correct. So that's why we did this study, and what we did was to commission some new surveys, all to run at the same time, containing the same gambling questions as had been asked in the health survey and in the YouGov survey. And we had 3 that were using probability sampling and 2 that were using non-probability sampling. So the idea is there, obviously, to get at, is it the sampling design that's really driving this? And all 5 of the commission surveys used online self-completion. 2 of them use a mixed mode approach. 3 of them use enable offline respondents to be part of the survey, 2 of them by telephone and 1 of them by providing a tablet and online access. So what we're going to do is compare the estimates that we get from those surveys to the health survey and the YouGov survey to get a handle on what is it about the differences in the designs of the surveys that leads to differences in estimates of gambling behaviour. So this is a key chart in the report, and it's looking at the proportion of people in the sample who have a PGSI score. That's the PGSI is the Problem Gambling Severity Index that we use to measure problem gambling and risk of gambling harm. And what this shows us, if we look down here, we get these low estimates for the health survey, and actually all of the online surveys that we included give us much higher estimates of the PGSI above 1 score. You see the Ipsos Mori survey here is a little bit lower. That actually is not directly comparable because the reference period for have you done any gambling is 12 months, whereas the rest of these are for 4 weeks. So what this initial comparison enables us to do is to rule out a few possible factors. One is sampling error. These differences are all statistically significant. We can also rule out coverage error. Really, are we kind of excluding some members of the target population from our survey? So obviously, if it's a fully online survey like YouGov, then people who aren't online can't be part of the survey. Similarly, the health surveys use the postcode address file to draw their sample. That does exclude some other parts of the population, like people living in military barracks or student halls, residents. So we can rule that out because we've got a mix of sampling frames here. We also rule out as unlikely that this reflects just a change over time, because these surveys were done earlier, and so it's possible that there was an actual increase over time. We think that's very unlikely that we would see this large an increase in problem gambling over a 1-year period. And also these later surveys were done during the first lockdown. And there's evidence from other surveys that actually gambling went down somewhat, although that was varied across groups. Gambling as a whole did go down. So we think we can reasonably rule out true change over time. That then takes us to a potential cause of this, which is differences in measurement error between the surveys. And there are a number of things that could have been going on here. One is that the PGSI battery is preceded by questions which really seek to identify whether a respondent has done any gambling in the past 12 months or over the past 4 weeks. And what we found when we looked at this was that the questions used were actually different for the online surveys and for the health surveys. They've kind of been updated in effect because gambling behaviour changes over time, and they've been updated to reflect that. There's a difference there, and that might have had some effect. There's also a feature of the health survey questionnaire. This is actually completed as a paper questionnaire during the face-to-face interview. And there's a part of it which indicates to respondents that if they say they haven't done any gambling, then they can skip some questions. Now that might have led some of them to say that they hadn't done any gambling when they had. The biggest potential factor is what we call social desirability bias, which is in effect that there's the potential that in the health survey there is underreporting of problem gambling because people don't want to admit to things in front of an interviewer. So that's an obvious potential cause of the difference. But we think that's unlikely because this is actually done using a self-completion questionnaire. And what we did in the report was to compare people who had completed the questionnaire with someone else in their household present compared to people who had done it on their own. And we found no difference in the level of reporting. So while each of these things could have made some contribution, we don't think that overall there's any sort of compelling case that was a causal factor of any magnitude. So that leaves non-response, or what we call selection bias, because we're not always using probability samples here. Now this could be the case because we know from existing studies that non-probability samples tend to give us less accurate estimates than probability samples. And that's particularly true of online behaviours. Also, we know that probability samples with low response rates are at greater risk of non-response bias than surveys with higher response rates. And that's the case that we have here, much higher response rate for the health surveys than for the online probability surveys. So what we've done is look here, there's quite a lot of information in these charts, which I'll try and simplify, but this is reports of different kinds of gambling behaviour across the different surveys. So the different coloured dots are the different surveys, and each of the boxes is a different type of gambling. Now you can see for National Lottery, there's a bit of a spread here, no obvious pattern. But there is a bit of a pattern when we look at in-person betting, which are these on the right-hand side here, where we see the blue and the red, which are the health surveys, are out to the right. So we tend to get more in-person betting for the health surveys, and on the left here, the online betting, we get higher rates for the online surveys. So there seems to be a bit of a sampling difference here, which is in a direction that we might intuitively expect. We get more in-person betting for the in-person surveys, more online betting for the online surveys. Another difference that we found was in the frequency of betting. So if we look here, the key comparison is that there are the proportion in the health surveys who say they bet more than once a week, considerably lower than it is for the online surveys. And we also see that at the other end of the spectrum, that many more in the health surveys say they only bet once or twice a year, or no betting at all, compared to the online surveys. Now, why does this matter then? I mean, because we can see differences in the types of gambling that people do across the surveys. How does that translate into problem gambling, the PGSI score? Well, what we've got here in this plot are the predicted probabilities from a regression model of people having a PGSI above 0. And so this is for different characteristics of gambling here. So what we can see is that people who do online gambling, their predicted probability of having a PGSI above 0 is quite high, as it is also for people who bet frequently. Okay, so what we're seeing is that the online gamblers are more likely to have gambling problems. What we can also do is look at how this happens. Why do we end up with more kind of online gamblers in the online surveys? This comparison shows us for the Kantar online probability survey, the rate of gambling and people's ownership of social media accounts the first time they were interviewed for the panel and when they were interviewed for at Wave 7 for the gambling survey. What you can see, there's a sort of a drift towards more people who are more online and people who are more kind of tech savvy, if you like. So we see this drift. People who aren't online and aren't tech savvy are kind of dropping out of the survey over time. So what we think is happening here is that there's a sort of bias selection into the online surveys, so that you've got more internet and tech savvy people in those samples. That sample skew of internet and tech savvy people, they are also people who are more likely to gamble online and to gamble frequently. And that means that online and frequent gamblers are more likely to report gambling harm. And that's how this difference between the online and the in-person surveys is coming about. So what do we make of all that? What are our recommendations? Well, we've got 3 main recommendations that we make from this. One, if you like, is a little bit counterintuitive, given the conclusion that we come to, which is that measurement of gambling prevalence and harm should move to online surveying. Now, that, as I say, is a bit counterintuitive because we've said that there's a bias there. But the reason we say that is because, firstly, at the moment, we can't do all face-to-face interviewing has had to be halted. But even then, even when we hopefully will be able to return to it, it's so expensive that it imposes real limitations on sample size and the frequency of surveying. You see, at the moment, we're doing surveys prior to the pandemic once every 2 or 3 years, and the sample sizes even then aren't what we can achieve with online surveys. So we think that that's almost going to happen inevitably. We think it should happen because it does enable us to do subgroup analysis and drill down much more in a fine-grained way. But because of this issue, we do need to have a program of methodological testing and development that is going to try and address some of the issues and some of the uncertainties. I mean, I say our conclusions are based on the balance of probabilities. We're not saying these things are certain. There are still areas of ambiguity around some of the measurement issues and so on that could do with some actually experimental testing, development, looking at different approaches to weighting the data. And we're not saying that we should stop doing in-person surveying at all. We think that would be an important future part of the program and work on this, which is to provide benchmarks. So perhaps every few years, the health surveys or some other vehicle might be used to include the gambling questions that can then be used to benchmark more frequent and larger sample size surveys. So if you're interested in the report, there it is. You can download it and read the full gory detail there. Thank you. I have to return to...
Thank you, Patrick. Thank you very much indeed. I love the way you put it, the whole gory detail. That's absolutely fascinating. And yes, I do find it fascinating that you should make the counterintuitive suggestion that you need more online surveying, given the figures that you've shown us there. But you also, a question has come in and the questioner says, you've recommended in-person interviewing as period benchmarks. So what are your thoughts about how often you think that those should be done? I mean, should you go for them annually or every 2 years or more often?
Well, I mean, I think that's really a case of sort of a cost issue. And as someone who's a survey methodologist who doesn't have to pay for surveys, I think they should be done very frequently. But the reason, I mean, I think there are good reasons why we have not been able to have annual estimates through in-person interviewing, because there just hasn't been the resource available. So I think it's probably unrealistic to expect that to change markedly in the years ahead. So I would expect something around a sort of a 3-yearly cycle, because we're, you know, if there is a shift of moving to a large sample online, there's still obviously expensive ways to do data collection, albeit not as expensive as in person. But I would think something around a sort of 3-yearly cycle for in-person benchmarking would be about right.
And another question, the questioner asks, you've recommended further methodological testing and development. Can you say a bit more about what that whole basket might look like? What's the ideal, I suppose?
Yeah, I mean, I think there were a few areas in the report where we, as you saw in my presentation, that we effectively had to say, given our sort of professional judgment here, is that this factor probably isn't contributing very much, given what we know from existing research, et cetera, et cetera. Whereas it would be quite straightforward to just do a randomized experiment. An example would be the questions that are used to detect anyone who's gambled at all in the last 4 weeks. They're different. You could easily randomize people to get one version or another version, and see whether that does make a difference. And there are a few examples of things like that where it would have been nice in the report to be able to rule out something like that, rather than say we suspect this isn't much of a factor. So that's one area. A few things around measurement and the sort of social desirability aspect would be part of that. We think there, you know, some could be some useful research done there, and also around the weighting of the samples. I think you know, our conclusion is that there is a kind of a non-response and attrition going on, which is leading to a sample skew. So there are ways that we could think about how to mitigate that, both in terms of how we go about collecting the data, perhaps incentivizing people. What are the effects of different ways of including offliners, that sort of thing. And also more statistical approach, you know, just actually sort of like, how do our estimates change if we change our weighting vector of variables that we're using, and so on. So I think there's a number of things that could be done to address our conclusions about the causes of the errors.
And Patrick, if I may, another final question for you before we move on. Will the prevalence surveys be markedly out of date due to COVID and a shift in online access to gambling? As noted, there's been a steady reduction in the physical betting, with mobile phone use by far the most prevalent access point. And in the northeast of England, comparing our data, we have also noted a ratio shift in male to female gambling. So, and it's quite a long question, and we will pass the rest of it on to you, but just given that flavour of it, can you give us a quick response?
That was, I mean, didn't have time to go into that, but that was obviously one of the big sort of confounding problems that we had, was that we were collecting the new data in a very different kind of context than the health surveys. And so what we did have, which was advantageous, was that the YouGov survey, the online, had been done in 2019, so just before the pandemic. And so we were able to sort of use that as because the pattern for that survey was very similar to the other ones. But that's certainly something that would benefit from further investigation as well. That's what the sort of part of the motivation for the benchmarking is, that we really need to sort of have this. Hopefully, when things are back to normal, we can do a kind of, you know, an online and a face-to-face benchmarking exercise that will address that level, that uncertainty that comes from that aspect of the timing.
Thank you very much indeed for that, Patrick. Thank you for your presentation. As I say, absolutely fascinating. As you said, we can read all the gory details, and that will be on the Gamblerware website. Let me introduce Dr. Amy Sweet from Gamblerware, and she's been leading the creation and development of new interactive, which use gambling harm prevalence data to determine the reported demand for treatment and support at a local level. Amy, these maps are becoming more and more detailed. Tell us more.
Thank you very much, Liz. Okay, I will just share my screen with you all. There we go. Hopefully everyone can see that okay. So yes, I would like to introduce you to our new interactive Gamblerware GB maps. These are now live on our website at the URL that you can see at the top. So after this webinar, at your leisure, you can go onto the website and have a look at the maps in more detail. So as Patrick mentioned, we commissioned a YouGov treatment and support survey, and that's been done on an annual basis. And the data that we collected through that survey has been used to create the maps that I'm going to present to you now. So the maps have been used basically based on the data to show a visual way of presenting data. So rather than lists and lists of data, we've created maps so that you can actually look at Great Britain, England, Scotland, and Wales, and you're able to see differences in gambling prevalence, in treatment and support demands across Great Britain. So we've got 3 maps on the website, and we take you through that in more detail at the top here. So the first map is showing gambling prevalence based on PGSI scores. The second map shows reported usage and reported demand for treatment and support across Great Britain. And the third map shows the relative usage and reported demand for treatment and support based on PGSI scores. Now, on the website, there's lots and lots of information about how the maps were created, and there's a specific report on the methodology and the sort of technical side of things. So for those that are really interested in how the data was modelled and how the maps were created, there's plenty more information on the website that you can look at. So really the aim of this presentation is really to take you through how to use the maps and the kind of the functionality of the maps. So the first map, gambling prevalence based on PGSI scores, you'll see it covers the whole of GB. And as you'll see, the window doesn't quite fit onto the screen, but the whole of GB has been covered. And as you can see, it's really easy with your mouse to kind of click and drag, and you can kind of navigate your way across the country. In the top left, there's a zoom function, so you can zoom in and out. I've got a mouse attached to my laptop, so I'm able to kind of manually zoom in and out. So you can pick an area that you're interested in and zoom in and have a look more about the local authority differences in that area. You'll see from the map as well that there's a colour scheme. This is based on quintiles. So quintiles basically just group the data into equal categories of 20%. So we can look at the top 20% of local authorities that have sort of the highest proportion of PGSI 8+, and also the quintile with the lowest proportion. So it's just a way of seeing what the difference is across the country. In the top right of the map, there's a little toggle button that you can click on. That gives you a drop down. And not only have we got the PGSI maps at PGSI 8+, which is the map that we can see now, but also we can look at the different classifications. So we can look at moderate risk gamblers, for example, and again, we can move around the map. We can look at low risk, so PGSI 1 to 2, and again, move around the map. And this year, as well as local authority level, we've also created ward level maps. So again, I can toggle over and we can look at that for PGSI 8+, and we can zoom in. And as you can see, rather than just look at the overall local authority score, we can now see the variations within a local authority. And this was created based on feedback from local authority colleagues who said, it's very, very interesting to know the overall picture, but actually it's really nice to look at the variation within a local authority also. So we boosted the YouGov sample for the most recent survey we carried out so that we could have the finer granular geographical detail. So that's kind of about the functionality of the maps. And again, there's lots and lots to look at. But what we think is quite interesting is this really creates a sort of starting point and provides an indicator of what the picture is across the country. And what we think is kind of a next step, which will be kind of aided by your own data sets and data sets across the local authorities, is to try and understand why there's this picture across the country. There's certain areas that have higher proportions of people experiencing problem gambling and are PGSI 8+. And this may be because there are demographic similarities in those local authorities. It may be there are similarities geographically. It could be linked to levels of deprivation. It could be linked to just the geographical kind of area that you're in. There's so many different reasons why there might be these patterns and these relationships. And I think we're very keen to kind of see this as a sort of starting point and an indication so that more work can be done to kind of uncover why there are these differences. So that's one of the 3 maps, and I'll scroll down, and again, the website has lots and lots of information to sort of take you through. But the second map that we've got shows the reported demand and reported usage for treatment and support across GB. And in exactly the same way, the map works in a completely the same way. And we've got this by local authority and ward. So we're able to toggle between reported demand and also reported usage. So it's quite interesting to zoom in and say, okay, well, this is the reported demand. Is the reported usage similar? And you can compare and contrast across the country. And what we found through the survey data is generally there's a correlation between the proportions of people that would like treatment and support and the proportions of people that are using it. And that may be because people may have had some initial support by talking to a family member or accessing a website. And through doing that, they may now want further treatment and support, whether that be seeing a GP or going to a counsellor, for example. So again, this map has really interesting patterns, and you can get a sense of where there's higher reported demand across the country compared to other places, and also where there's more usage of treatment and support. And then finally, we've got the final map. And really, this map was created because we wanted to find a way of overlaying the 2 previous maps. So we understand from a sort of a local authority perspective that you're interested to know, do we have higher proportions of people experiencing gambling harm in our local authority? Are people in our local authority or ward areas accessing treatment and support or wanting treatment and support? And what is the correlation? So we basically created these maps which show where there are areas where there are higher proportions of people that are PGSI 8+, for example. And again, we can look at this for all the different PGSI categories, but this is the specific one for 8+. So the orange and the red sort of areas show where there are higher proportions of people who are PGSI 8+, but these people aren't then accessing treatment and support. There's much lower levels of usage and demand for treatment and support. So it's just flagging where there might be areas where there's sort of like potentially unmet need or unmet demand for access for treatment and support for people that need that treatment and support. So again, this is purely to indicate, it doesn't necessarily mean that there aren't services in that area, but it's just flagging where there's a lower level demand based on a higher prevalence of gambling harms. So you will be able, as I said, to look at this at your leisure. There's plenty of information on the website. There's also some really useful resources available for local authorities who want to support people experiencing gambling harm. And as I say, it's on our Be GambleAware website and can be accessed. We're really, really keen for any feedback. So we've included our research@gambleware.org email. So if anyone has any questions that aren't answered in today's session or want to have some further information, please do drop us an email and we can answer that for you. Thanks very much.
Amy, absolutely fantastic. Thank you. What a brilliant resource, and obviously something that you've put an awful lot of time and effort and thought into, and I imagine there will be quite a lot of questions. Stay with us, because we want to hear from someone who is using the tools that you're making available, just to see how that's going. So Amy, if you stay with us, Joe Evans, Joe is from Greater Combined Authority, and she's going to look at how the data collected by GambleAware helps to determine the big picture of gambling prevalence in her area. And Joe, to what extent does that allow you to plan the treatment and support for gambling harms that your area needs? Over to you.
Thanks very much, Liz and Amy. I'm just going to pop my slides up, so bear with me for 1 second. Hopefully you can all see those there. So as Liz says, my name is Jo Evans, working in Greater Manchester. You can see that we are, you've probably heard from me presenting before at various different events, but we're taking forward a city region approach to gambling harm reduction across the 10 localities in Greater Manchester. And within that area, we have a population of approximately 2.8 million people. So we have a really good size of a population to be working with, and a lot of diversity within that population, which makes things really interesting. In our programme, we have 4 key priorities that we're working towards. So the first one of those is to really build an understanding of the extent and impact of gambling harms across the population within Greater Manchester. Secondly, we're working to provide equitable access to high quality treatment and support for those who need it. Thirdly, we're working to develop and test interventions to prevent harm from arising in the first place. And fourthly, we're really keen that we make sure that we work and involve and engage with individuals and communities across Greater Manchester and also lived experience sector within that programme. So from those priorities, you can probably see that this work fits into the first 2 of those, particularly around understanding the scale and impact of gambling harm reduction. So as we kind of have started on this journey, these are some of the questions that we're starting asking in terms of what can we find out about gambling related harms? Where can we look to find that information? So you can see kind of the whole range of questions that we're starting to think about. How many people are experiencing harm? You know, who are these people? How do they differ from people who don't experience harm? Is there something we can learn from that? And also, how do people experience harm? When we just talk about gambling prevalence, we need to understand what does actually those harms mean and what is the impact on our communities and societies. Then looking forward to where the costs and benefits of gambling lie and where we might want to develop our interventions around that. Are we providing the right support for people that are experiencing gambling related harms? What can we do about this? Where should I focus my efforts? And also finally, kind of as we're learning through this programme, is what we're doing making a difference? So Amy kind of came to me and said, you know, how we've got these maps, how might you want to use them? How is it useful for you in your kind of city region approach to gambling related harm? So I kind of been thinking about it, and these are some of the practical uses for the data that Amy's just presented. And you can see there, I cut that down for problem gamblers across Greater Manchester with the PGSI greater than 8. And we can see both that there's a really high concentration of people experiencing problem gambling within Greater Manchester, but also you can see there's quite a bit of differentiation between the different wards, and I think that's really, really helpful for us to understand at a more local level, and particularly working within a local authority, is understanding where those populations and communities might be that are at greater risk or greater vulnerability, or are in fact have greater extent of prevalence of problem gambling. For example, people that don't know Greater Manchester, it's really hard for you to see, but to the kind of the bottom left of the screen, we have Trafford, and we can see that there's kind of a differentiation as you look down as kind of an area of low prevalence into an area of higher prevalence and then back down into lower. So it's really useful to have that breakdown at a more community ward level approach. So that's really, really helpful. And then where can we apply that understanding? Particularly kind of the first thing that came to my mind is thinking about, we're developing our gambling licensing policies, and the Gambling Commission has updated the guidance on those policies, and they're all due for an update this year. So we're going to be using this data to inform those licensing policies, inform our local area profiles and our risk assessments, so we can have a really kind of informed approach when we're working with operators to say, well, look, actually we have really high prevalence in this area. Therefore, we think it's really important that you do step up kind of your safer gambling measures, and that we do a lot more that we can do to enforce and protect our population there. Where else is it useful in terms of reviewing provision of treatment and support services? Is thinking about, are they located in the areas of greatest need, and are people accessing them? Are they working as well as they should be? And I think it's really interesting, again, looking at the GambleAware commissioning strategy that's coming out. It's very much looking much more at kind of integrated provision and working at a local area to understand, are our services and the provision that's available currently, is it working for your local populations? We can use this data to start to understand some of that. And I know where the location of our clinics are, and this is really making me think, well, hang on, perhaps we need to think a little bit differently, because we don't have one in any kind of local provision based in central Oldham, which is towards the top right of the screen there. And so do we actually need to focus on that? What about central Manchester? Do we have any provision there? Where are people accessing treatment and support? So that's also really helpful for us to think about some of those decisions and to work with our local providers around that. Thirdly, it's really, really useful also just to kind of raise the profile of thinking about gambling related harm within our local strategies, thinking about, is it our public health strategies, is it our poverty reduction strategies, our financial inclusion, our COVID and kind of social and economic recovery from the COVID crisis. We can really use these maps to build a case that says, actually, we really need to be thinking about gambling related harm within a lot of the work that we're doing locally. And here, this is why it's important in this area. So I think it's really helpful to do that. Another thing, you look at a map, it immediately makes you start asking questions. And I think that's really, really important. I think it's important to understand that the maps don't tell you anything. Therefore, using these maps can be used as a platform and a stimulus for discussion. What does this tell us? What do we know about our areas? Does this feel right, or do we know something else that's going on that it might tell us a different story? But having these maps, having it visually presented as opposed to some kind of raw numbers, I think it makes it much more compelling and engaging, and it helps stimulate that discussion. So that's something that I'm going to be hoping to have with our local partners in Greater Manchester. And I've already mentioned around building a compelling case for change. So going back to some of those questions that we were asking about what do we need to understand about gambling related harm, I kind of highlighted here in yellow the areas where I think that this tool can fit and can provide some input. I think what's really clear is that it's not the only tool that we should be using, and there's lots of other things that we should be looking at in order to complete the picture and complete our understanding. So whilst it is really, really useful, we need to use it in combination with other data, other analysis, and from that I'm thinking about, it's about lived experience, input and insight. It's about thinking about, how do people actually experience harm? What does that actually mean for an individual when we say that someone has a high PGSI score? What does that mean for them? What does that mean for their family? What does that mean for a community? If we're looking at ward level at data and we can see there's a really high level of prevalence of problem gambling, what does that mean for the opportunities and life chances of people living in that area? So we really need to think about some of those things. And there's also a lot of things that it doesn't tell us in terms of, is what we're doing making a difference? I think from kind of the methodology things that Patrick was talking about, is we can't necessarily look at it longitudinally yet. So in terms of, is what we're doing making a difference? It's not going to tell us whether we're really seeing change over time. That's my take on it. I'd be interested to hear whether that's the correct take or get some feedback on that. But just thinking about kind of some of the challenges and where we want to go next. Like I've said, it doesn't cover the whole picture. It doesn't have any inclusion of affected others and also legacy harm. So people that might have been harmed kind of either in their growing up or also kind of still in recovery from gambling related harm. So we need to understand that it doesn't tell the whole picture, and we really need to make sure that we're triangulating other data from affected others. We need to be really clear about how we communicate those maps, think about some of the caveats of survey data and the methodology, triangulate it and bring it together with some of that local knowledge from those discussions that you've had. And then finally, just to kind of make the point that actually, as Amy's kind of said, this is all part of a journey. We want to use this learning to kind of understand what does it mean as we're developing a local and regional approach to gambling related harm. Really quickly, there's those 4 bullet points of what the GM approach is including and how we're looking at building that, but I won't go into that in detail, just so our time and to give time for questions. So just to say kind of, finally, you know, all of this is part of our public health approach to gambling related harm. If you see me presenting, you will have seen this slide before, and I will continue to use it forever. But just to say kind of that kind of really important thing is we need to be informed by the best available evidence, and this really contributes to some of that. It may not be absolutely perfect, but it helps us and it moves us on in our understanding and our journey. So let's make sure that we're using it in the right way. So I will leave it there. I'll hand you back over to Liz, who can hopefully help us answer some of those questions. So thanks very much.
Jo, thank you so much for really bringing it to life. And I know you say that the maps are just one tool, and I think that's a very, very important point to make. The questions are flooding in. So Amy and Jo, perhaps you can answer some of these questions. Amy, I think a question that asks, can the maps split out genders so we can see prevalence of the PGSI 8+ men versus women? A very practical question there. Is there an answer to that one?
So we're not actually able to map that data, but we do have the data available as part of the treatment support survey, which splits the data by gender, ethnicity, socioeconomic status, various other different demographic variables. So it is possible to look at a local authority level. We just haven't been able to model that data and map it at this stage because of the sample size. But it is something that we could consider doing for future surveys, but yeah, the raw data it will be available if that's what you're interested in.
And another question along those lines, is the data available as a downloadable spreadsheet as well?
Yeah, so we're actually working to make our treatment and support data and the map data available for people to use. So we're actually working on an agreement at the moment where that will be hosted on an external platform that researchers can access. So hopefully within the next month or so, we'll be able to share information about how that data can be accessed so people can do their own research and analysis using that data.
And another practical question, I assume the map is weighted for population. Does it also come with associated deprivation index overlay, as rightly suggested an issue by the speaker?
So the data's all weighted. There's actually on the website that I was presenting earlier. There's technical information about how the data's been modelled and weighted. So for those that want to understand the methodology in more detail, that information is all there. In terms of looking at other variables, obviously we've got the ward and local authority level data, so that can be compared to other data sets, and I'm sure lots of local authorities will have that data available at those geographical scales. In terms of mapping, those are the only maps that we have at the moment, but there are maps that show, for example, the index of multiple deprivation and other classifications that can be compared against our maps at the same geographical level. So there is lots of possibilities to compare against other data.
And again, will the data be updated at another point, i.e. every 2 years or so, to see how much the picture at a local level changes?
Yes, so we are at Gamblerware committed to running the GB annual treatment and support survey every year. So we will be updating the data on a yearly basis, so we can look at change over time to understand if there's any kind of changes in the data, but also geographically. So the maps will be something that we will continue to work on and continue to improve. So again, we're really keen to have feedback from sort of colleagues across GB on what might be useful. Obviously, we have to think about what's possible with the sample size that we collect, but we're really interested to know if there's anything that other people would like for us to look at in the future, or what might be helpful, because this is kind of a continual process that we're improving year on year.
And of course, it's early days yet, but Jo, I mean, are you already thinking it would be useful to know X, Y, and Z that isn't already included?
Yeah, I think that there's loads of things that I think we would like to have a look at and see included in this data. I think it would be, even that kind of, somebody mentioned that split of kind of genders across different areas. I think that would be, that's kind of a next step, and I think it would be really useful as we look to start using it in terms of the questions people are asking of the data. Like you say, it's early days, so we haven't really played with it lots. But yeah, where does this go next? I think it's really key, and I think it's great that kind of Gamblerware are kind of committed to making that data available for local areas. So I think that's definitely something that we're going to be doing in terms of downloading our sample area for Greater Manchester and having a look at that and understanding that. But yeah, there's definitely lots more places where this can go.
And Patrick, you're with us, so please, if there's anything you wish to chip in when we're going through these questions, then please do. But there's a question here that is interesting. How is reported demand defined? Anyone? Amy?
Yeah, I think that's probably a question for me. So as part of the YouGov survey, we asked, one of the questions was, would you currently want to receive support, advice or treatment from the following for cutting down on your gambling? And then there was a list of various different support options, such as, speaking to a family member or friend, accessing a website, to things like going to see your GP or counselling. There was about 16 or 17 different treatment and support options. So if somebody said, yes, I would like to see my GP, or I would like to speak to a friend about my gambling, we would then obviously, that would indicate that that's reported demand. So they're reporting that they would like to receive some sort of form of treatment and support. So that is how we collected that information. It's from the self-completed survey that as part of the YouGov treatment and support survey.
And I think, sorry, can I just come in on
Yes.
that? Is the actual access to treatment data that we have? I think in terms of like, where could we go next? I think that's almost potentially a next step, because we know we do have data on access to treatment and provision. So at the moment, we're going to be triangulating that locally and asking those questions. But yeah, in terms of building future layers, is adding to that reported with the actual and understanding, is it the location of places? Are there other barriers? And just bringing together all of that. What are the reasons for accessing treatment?
Thank you very much for that. And I do want to ask all three of you where next, just before we close. But there are another couple of really interesting questions. One says it would be interesting to compare these results to the GeoFuture Gambling Harms and Risk Index work, which models local population characteristics to explore local variation. Also concluded that area deprivation wasn't the answer in explaining this variation, but that you also have to take into account the supply side factors. Could this be factored in too? Amy?
Yeah, absolutely. I think again that sort of links to a previous question. I think about how can the maps be used to link to other data, and I think this is again very early stages. And I think you're going to ask me, Liz, about next steps. And I think one of our aims moving forward is to create kind of a steering group with representatives from local authorities to kind of find out what data is available and how we can best kind of create our maps to sort of support the needs of people in local authorities, and to find out what other data is available, because all the time I'm discovering new sort of data sets and new pieces of work that people are working on, and it's really great if we can link up and actually sort of link our data together, because I think that's when it's really telling. Our maps at the moment are they're indicators, but we need to do further work and there's more evidence needed to understand why there are certain relationships and patterns across the country.
Patrick, is that something that you want to come in on?
It's not really one of my. I mean, in terms of your question of where next, I mean, I think the sort of issue is in our recommendations. I guess we set out what we think the future holds there. I see there's a question come in about kind of suggesting we should move away from self-reports to use behavioural data for measuring gambling harm. I think I don't think we can really. I mean, one can approximate it, but when one wants to measure psychological states, really the sort of best way of doing that is to ask people how they feel about things and how they behave and so on. It's difficult to sort of scrape data or get it from administrative sources.
Yeah, and just to read that question in a bit more detail regarding prevalence of harm proposals for a single customer view, or a system whereby cumulative account data is available across any outlet where someone gambles, would surely negate the need for single report surveys or interviews. Furthermore, it would provide objective behavioural data. Shouldn't we be working towards this rather than better self-report surveys? It sounds ideal, but from what you're saying, very difficult to deliver on.
If you've got measures of how frequently people are gambling, I mean, that might indicate that they've got a problem, but it might indicate that they've got a lot of money and they like gambling. I mean, so it's not to say that data is not useful. I'm sure it is, and potentially combined with self-report. But I'm still a believer that if you want to understand people's psychological states, it's difficult to infer that just from their behaviour. You basically need to ask them. So I do think, while it is a very difficult thing to measure, there's no doubt about, both in terms of measuring the concept of interest and in terms of sampling and inference, it's a very difficult quantity to estimate, and that's why we need more methodological research.
So we do now come on to next steps. Amy, what's next for the maps?
Yeah, so we're hoping over the summer to sort of put together a working group, a kind of steering group with people from across the sort of GB local authority network, and to look at what do they need, what data is available, how we can kind of improve the maps moving forward, but also to link up with other data that's available. So getting to know, I know from today, from some of the questions, there's data sets that have been mentioned that obviously we're not aware of, and actually it would be great to find out more about what else is being collected, so that we kind of complement what's already out there. So yes, we'll be certainly getting in contact with probably many people on this webinar today to get feedback, and also to look at building a group of advisors so that we can kind of keep improving these maps year on year.
Now, obviously we've been talking to Joe, but how many other local authorities are involved at the moment in using these maps?
Well, we'd hope that there's quite a few. I think from last year when we first launched the maps, we spoke to, I think, 5 or 6 local authority representatives who were helping us to sort of make the maps better again for this year, which is why we've now got ward level maps as well as local authority. But we'd like to grow that and sort of connect up with as many people as we can to kind of make sure that we're kind of improving the maps, and that they're going to be used by as many people as possible.
So if you're on this webinar, it may be you. Joe, what are you thinking? What next?
I think in terms of us for in Greater Manchester, what next? I mean, it slightly builds on Amy's point in terms of hearing from what's happening in local and city regions. I think we're going to be we're doing some work at the moment around building our understanding of gambling related harm in Greater Manchester. So that's going to be including and bringing together prevalence estimates of gambling disorder and people at risk of gambling harms, looking at pulling in together affected others within that picture. So it's not just the gambler, it's about the people affected by that gambling. Also kind of using qualitative insight, life narrative accounts to really understand what does that mean for somebody's life, and tell us your story, bring flavour and kind of reality to what some of these that look kind of quite impersonal numbers and figures look like, and really tell the story about what that means. And then also we're going to be looking at, from kind of a whole kind of regional, what are the actual social costs of gambling related harm? What does it mean for our society and our communities? Is it that people aren't getting on in their jobs as well as they could be? Is it that, looking at the impact on criminal justice, looking at the impact on our health service, and then kind of building that case for a more preventative approach? So for us next, it's going to be about kind of consolidating all of this data at a local level, and then hopefully using that learning from the work that we're doing to help others and to work with Amy and others with that. So that's probably what's next for us.
Thank you very much. And tell the story, always tell the story. I think that's what makes it relevant for people. And Patrick, of course, you want to see your recommendations. You've set out your next steps. And so thank you very, very much indeed for presenting your review, letting us know what those recommendations are, to Amy for telling us how the maps work, and Joe telling us how we can put all of this information to great use. Thank you all for joining us. Thank you for attending. And all I can say is it's the sun that's shining out there where I am. Hopefully you all managed to get a blink of sun in the outside world during the rest of the afternoon. Thank you for joining us.